Good afternoon, everybody. So I will be so I will be talking on adaptive radiotherapy in lung cancer. The problems in lung cancer are poor survival to the tune of 5 to 10%, stage 3B, high local failure because of with chemoradiation, high toxicity, and there's a lot of anatomical variation and motion of the lung, which results in decrease in the therapeutic ratio. The variation during the radiation are setup errors, which are taken care by PTV margins, motion of the lung by motion management strategies, interfraction anatomical changes by adaptive strategies, and biological functional changes, which will be dealt with adaptive strategies. The tumor lung dynamics during the chemoradiations are mainly the tumor anatomical shift or regression, atelectasis, pleural effusion. Let's talk each one by one. Effusion, which will change the tumor lung dosimetry because of the addition of the effusion. So if the baseline effusion is present, better to get rid of it. And B5 less than 41% has been recommended as a threshold to decrease the to decrease the effusion. Atelectasis, which means the imperfect expansion. It is caused by a tumor near the bronchial airways, which is obstructing and causing reabsorption of the air in the alveoli, leading to atelectasis, which on contrast CT appears to be hyperintense or enhancing. And during radiation, chemoradiation, if there is a resolution of the atelectasis, it will cause displacement of the GTB. As you can see in the diagram in the extreme left at the baseline, and during radiation at 50 gray, there is a shifting of the target towards the posterior side. And
Mama,
third,
hand wash अच्छे से.
hello. Yeah. So now coming on to the third change is the tumor shrinkage, and a daily CBCT is the most practical way to assess this. There is a GTV reduction of around 20 to 40% during radiation, and authors have reported to a 1.2% volume reduction per day during the CRT. These are the magnitude of tumor regression during chemoradiation to the tune of 20 to 40%. In our study published in 2014 in JCO and BGR, there was a reduction of 34%. And how does the macroscopic disease regress, and what is the impact on the lung anatomy? In case on the extreme left, you can see expansion of the adjacent lung because of the regression. On the right side, you can see the unwinding of the pulmonary structures because of the regression of the tumor. And what is the impact on the microscopic disease, which is a very important aspect. In case of infiltrative growth pattern, as you can see, there is the microscopic disease remains stationary. It can be asymmetric regression, or in case of expansive growth or expansile growth, there can be a synchronous regression of the microscopic disease also. So what are the dosimetric consequences if you don't go for the morphological, if you don't go for adaptive planning? There is a higher dose to the lungs, which we have found in a study published by my colleague, Dr. Deepak, and a higher dose to the ipsilateral lung, mean heart dose, and a higher dose to other structures. And this has also been validated by other studies also. So if you are treating on a single CT scan, it will lead to incorrect dosimetry. That means a geographic miss, higher dose to the OARs, as you can see in the upper panel and lower panel. So what is the solution? The solution is adapting to the changes, that is modifying the contours to changing morphological or functional anatomy during the treatment. So basically the adaptive radiotherapy, this is called ART or adaptive radiotherapy, and it has got three philosophical aims. That is, one is to maintain the prescription dose to the target. Second aim is dose reduction to the ARs, although both of these are intermingled. And third is dose escalation with isotoxicity to the OARs. And what are the level of adaptation? It can be a point adaptation, volumetric, and biological adaptation. Point-based adaptation is as same as the IGRT, which we do a CBCT and matching and then correcting for the setup errors. When we do a IGRT, what to match? Do we need to match spine, carina, or soft tissue? Studies have shown that the best would be a spine, the carina matching in case of lung treatment. The other are volumetric adaptive radiotherapy and biological, which I will be dealing shortly. So lung adaptive radiotherapy, the first philosophical aim was to maintain the dose, and secondly to the OAR, to decrease the dose to the OARs. So both, as I've discussed, both of these aims are intermingled. Maintaining the dose to maintaining the prescription dose and preventing geographic miss is one of the aim. And so at the same time, when the tumor will regress, there will be lesser dose to the OARs, like as you can see in the lower panel to the lung. Um, uh, Studies have been done with the adaptive radiotherapy when in case of there is a pleural effusion or atelectasis. This study published in Green Journal, they evaluated on CBCT effusion if it was more than 1 centimeter and atelectasis if it is causing more than 5 millimeter of geometric shift. They recalculated the dose. They found that almost half of the patient which they required the adaptive treatment, and almost 85% of the adaptive plants involve in some form the atelectasis, either appearance of new atelectasis or disappearance of the old atelectasis. So dosimetric, this is the dry run of the RTOG 1106, in which there is improvement in the O, because of adaptive improvement in the dose to the target and decreased dose to the OARs. But there is a concern which we face even when we published our paper in 2014 regarding the underdosing of the microscopic area if you are reducing the volume. This simulatory study, model study was done by Kuchenberg and published. They have found that the adaptive radiotherapy do not compromise dose coverage and tumor control probability in both the scenarios if it is an infiltrative or expansile growth, or it is a synchronous or asynchronous microscopic disease. So, and adaptive radiotherapy improves the overall tumor control probability by 40%. This is the clinical study, Lartia study published recently from Italy. They investigated the risk of local recurrence in the area excluded after replanning by doing a weekly CT scan, and they found that adaptive radiotherapy is totally safe with acute and chronic pulmonary toxicities grade 3 and above very low to the tune of less than 4%, and marginal recurrences were less than 6% of marginal recurrences. So now the two aims I have discussed, the dose modification and OAR reduction. And third, what about the dose escalation? As we all know, RTOZ 0617, the 74 gray arm failed because there were higher recurrences, more mortality and toxicity in the high dose arm. So is this the end of line for dose escalation? Probably no. Multiple strategies, including the limiting radiation dose duration to 6 weeks of overall treatment, motion management, individualization of radiation dose based on achievable mean lung dose, morphological and biological adaptive strategy may be the answer. The lung adaptive radiotherapy for dose escalation has two aims: to increase the dose without increasing the side effects. So there is an important role of functional imaging in this adaptive radiotherapy. Functional imaging in the form of SPECT, PET-CT, MRI. SPECT, ventilation perfusion scan, can identify a physiologically functional lung. And this study was done comparing the anatomical based plan and the functional based plan based on the ventilation perfusion SPECT scan. As you can see in the DVH, with the use of ventilation perfusion's functional imaging, the lung could be preserved. The lesser dose was received by the functional lung. So there is a decreased dose to the OAR. And now coming on to the PET, we all know tumors shrink more on PET than a CT scan. This study compared the rate of regression in the mid-treatment scan, PET and CT scan. They found 70% of the PET metabolic reduction was there versus 40% CT GTV reduction on the mid-treatment scan. This PET plant CT are open randomized study published in Lancet recently. They compared the PET-based dose escalation versus the normal dose escalation with this same mean lung dose. They found that the dose escalation was possible with PET-based plan, but not with the conventional target group, conventional planning. And there was a 50% reduction in the local regional progression on PET adapted group. Then there was a phase 2 clinical trial, must talk by Kong et al., which has escalated dose up to 86 gray in 30 fractions, a BD of 120, with the use of PET imaging, metabolic volume dose escalation treatment. And they found that the dose escalation to the FDG avid tumor was safe and improved the local regional control. So this forms the basis of RTOG 1106 dose escalation trial, big smart trial of NSCLC in which there were two currently ongoing. The two arm, the control arm is same as the RTOG 60 gray arm, and the second arm, experimental arm, they gave a EQ2 of 50 gray in around 20 fractions, and then they repeated the PET scan and the metabolic volume, metabolically active volume, they escalated the dose to the B of 120 gray and EQ2 of 92 gray. So this is currently going, results are awaited. The role of MRI in case of adaptive planning. The MRI guided Linux provide the superior software resolution. They permit the online adaptation based on daily volumetric imaging. There is a real-time gated treatment delivery, and so we can use a small PDV. There is a potential of reduced toxicity and improved control rate. As you can see in the study published in Red Journal recently, they have evaluated the in high-risk lung tumors. They used the MR guided and found it was safe. Dose escalation could be possible and control
Hello,
was better.
Mr.
Uh,
Lim.
2 minutes left, Dr. Shyam.
Okay, ma'am. Now coming on to radiomics in adaptive radiotherapy, the radiomics use
Yeah.
these 3D gray value into statistical and textural features. And as this horoscope can predict about this girl, similarly the textual and statistical features, that is a machine learning or artificial intelligence, can predict about the tumor before the start of treatment into the responders, partial responders, and non-responders. Study published in Green Journal recently, they predicted 7 pathological features for gross residual disease and 1 features for pathologically complete response. So, and it is also available, it can also be doable in the CBCT. So when to adapt? It is normally a subjective looking at the images, but it can be a pre-planned also in case of large tumors and change in CBCT. If you are doing a CBCT, if there is reduction in the tumor in more than 1 centimeter in any of the dimension, shift in the visible tumor outside the PTV is going outside the PTV. Difficulty in localization of the tumor, which is close to the atelectasis or effusion, if there is a gross shift in the mediastinal structures more than 1 centimeter, or if there is a dosimetric variation, then that may be a trigger for the adaptive radiotherapy. If the GTV decreases more than 30% in first 20 fractions, that also be a useful trigger point. Many studies, they quote around 15 to 20 fractions is the ideal time to do adaptive radiotherapy, and location of tumor is also important, peripheral versus central tumors. There are lookup tables which compare GTV reduction versus the lung sparing with the adaptive radiotherapy. And how to adapt? Key components are doing a CBCT, dose deformation, and treatment modification decisions, and adaptive treatment modification. There are automatic segmentation tool available which use the density model to predict when we can go for adaptive planning. They on the CBCT they do the automatic dose deformation, and they flag when a CB adaptive radiotherapy is required. The overall sensitivity of such approaches around 95%, although they are very new algorithms with a false positive rate below 19%. This is on the left side the CT scan, right is the CBCT. They convert the HU value into mass densities, and they do a rigid registration, and the discrepancies in both the CTs, they map out in the tumor area, mediastinum, and the lung lesion, and based on the algorithm, they can predict when adaptive to be done and not to be done. And there are some deformable registration tools also available for this. So take home message is, if there's a large tumor or significant atelectasis or effusion, then you pre-plan the adaptive radiotherapy. Do a regular assessment on CBCT, at least weekly, otherwise twice weekly or daily if possible. And if there are any significant changes in the CBCT as compared to the baseline CT, then you go for it. If and adaptive radiotherapy results are better if it is performed between 15 to 20 fractions. For dose escalation, if you are attempting with adaptive radiotherapy or dose escalation, try to keep the mean lung dose less than 20 gray. That is isotoxic effect. So this is all I have to take. Thank you so much.